Hello, everyone. Welcome back to Medscape Psychiatry. I'm Dr. Drew Ramsey. I'm an assistant clinical professor of psychiatry and part of the Medscape Psychiatry editorial board. And I'm here with a very special guest. Dr. Mann is a professor of translational neuroscience in psychiatry and radiology. And he's also the director of the Columbia Depression Center. Dr. Mann, welcome. You're also someone who taught me neuroscience way back in the day when I was a resident. And so I wanted to speak with you because as a clinician and as someone trying to translate science in some ways like yourself, I think a lot of us clinicians are confused after this systematic umbrella review came out, questioning really one of those bedrock principles of depression treatment and mental health treatment, which is the serotonin hypothesis of depression. So, Dr. Mann, first, can you just tell us a little bit about your work at Columbia Psychiatry? You really have a storied history in both research and clinical work.
So yes, we are interested in. We've been studying for many years the neurobiological basis of mood disorders, major depressive disorder, and bipolar disorder. We're interested in both the genetic and the environmental or epigenetic effects that create the pathogenesis of these illnesses.
Yeah, I think for those of us in clinical practice, I think about you as one of our generals, in the sense of really helping us understand where are these illnesses coming from. It's never felt satisfying as a clinician to have a general explanation, and it's really been inspiring over the last decade to see a lot of new science coming out. So can you tell us about this umbrella meta-analysis? And really, when you saw it, what was your first reaction? What did you think?
I read the paper. I found it's really a fairly mediocre paper. It took several selected aspects of studies of depression, mostly focused on the serotonergic system, and it really didn't kind of help the reader because it didn't separate pivotal landmark anchor papers from a lot of poorly designed papers with small samples, so it kind of then took a vote, in a kind of, as meta-analyses often do, when it lumps together poor papers with good papers and gives them all an equal vote, and then says, here's the scorecard. And the result is actually more confusion than enlightenment.
There were several aspects of the paper that were confusing. I think one is the notion of a chemical imbalance. As a clinician, I've always felt, believing in biology and science, that when things aren't feeling good for me upstairs, something's going on biologically, because most feelings, I would say all of them, have something to do with biology. Is it true the chemical imbalance hypothesis is just wrong and we shouldn't think about that or explain depression like that to patients anymore?
Well, I think that first of all, we need to remember that there is a significant genetic component to both MDD and bipolar disorder. So that means that there is a biology out there that's at least partly genetic. Then we also know that adverse childhood experiences significantly increase the risk for the development of a mood disorder in adulthood. And we also know that these illnesses are transmitted to a greater degree than just genetics in families, which reflects this combination of factors working together. Then when you look at it from that perspective, then you know that there is going to be biological abnormalities in people who suffer from depression. The question is, what are they and how well can we understand them? So as best as we can tell right now, there's an array of abnormalities in people with depression. One group of abnormalities are in the serotonergic system. A second group of abnormalities are around inflammation. A third group of abnormalities are around the HPA axis and cortisol and stress. There's a list of neurotransmitter systems in addition that also show abnormalities, which include the noradrenergic system, the dopaminergic system, the GABAergic system, and the glutamatergic system. And then when you go through the array of medications that we have discovered, mostly by accident, that are good antidepressants, we find that they target all of these things. So that is a remarkable collection of convergent information that points to the fact that there are biological abnormalities.
I wondered whether the author's goal was to expose the public or inform the public of all of the new science. And I felt that was missing, that, okay, maybe the evidence for serotonin isn't as strong, but no one has been saying serotonin's the only game in town for a long time. You've been interested in these other systems, the GABAergic, glutamatergic system, since I was a resident 20 years ago. In addition, there's a whole new interest in inflammation and neuroplasticity. I'm wondering if you can share with us a little bit of how you now think of depression. There's a convergence of these systems, but are you beginning to see some genetic subtypes? Are you seeing involvement of neuroplasticity or inflammation in ways that excite you as a clinician scientist?
We actually don't care whether those studies have found much or whether there were studies that didn't agree with earlier studies and so on and so forth. Their relevance for the brain is pretty limited. It's the studies that focus in on the brain that are the ones that are of most interest. But, and in fact, when we look, now there have been more recently some very much more comprehensive brain studies using PET scanning and postmortem brain tissue, which have find reinforcing complementary sets of observations that definitely implicate the serotonergic system, but also implicate other things as well, like inflammation and neurogenesis. These are not independent of each other. These are all linked together. So just to give you some broad strokes, we know that the serotonergic system is not just a neurotransmitter system, it's a growth factor system. This is a separate and ongoing process. Serotonin plays an important role in early brain development, but it also plays a fundamental role in ongoing brain health throughout life. So that we can see now that, for example, if you look at the brain of individuals who died by who suffered from, say, MDD, the dentate gyrus, which is part of the hippocampus, where neurogenesis occurs in adulthood, is half the size in depressed patients. But if those depressed patients died while at the same time being treated with an SSRI, it's not half the size, it's normal size. Then if you go and look inside the hippocampus, dentate gyrus, to find out why, you see that they've got the untreated depressed patients have half the number of mature granule neurons in their dentate gyrus. They have less angiogenesis, which is like the supply of nutrition to the neurons, and the processes and so on are shortened. So everything is diminished, which explains why when you just look at the whole volume of the dentate gyrus, it's half the size. But if you look at the ones who are taking SSRIs, you find several big differences. First of all, the number of mature granule neurons are the same as in controls. They don't have that deficiency. And then you see that angiogenesis is also comparable to controls. But even more striking, you see the reason for that. You see that the multiplying neuronal progenitor cells are way more than normal. These medications increase the rate of multiplication of these progenitor cells, which allows reversal of a depression effect, so that the brain normalizes. So when a doctor is treating a patient with an SSRI, it's not some kind of symptomatic relief, like when you take Tylenol for a fever. It's actually more like an antibiotic. It's actually, the antibiotic kills the infective organism. The SSRI turns on progenitor cells and causes a catch-up in terms of turning on the pipeline of producing neurons so that the dentate gyrus comes back towards normal. So you're actually doing something fundamental for the patient. The longer they stay in this state of depression untreated, the worse the condition is getting. The sooner they start treatment and the more consistently they stick with the treatment, the sooner they're going to get on the path towards normality. But meanwhile, inflammation is tied in with this. Some of the inflammation is protective, some of the inflammation is damaging, like in many medical conditions. And we still don't fully understand that mix, but we're learning about it and we're busy studying it. So you begin to see how all of these things are kind of connected. The HPA axis is overactive. That's damaging and interfering with inflammation and protection, and maybe increasing the rate at which cells are dying. And the glutamatergic and GABAergic systems are out of balance. You have too much glutamate, which can be neurotoxic, and you have not enough GABA, which is supposed to be inhibiting the excess glutamate release, protecting you. So there's a whole bunch of things that aren't right. And we know, at least for some of this, how our antidepressants may be working to fix the problem.
Thank you, Dr. Mann. That is very helpful, I think, for all of us who are both prescribing, thinking around the notion of serotonergic medications is working towards helping growth factors or helping growth within the brain and protecting the brain. That's very striking. That also helps in terms of long-term use. Many patients who with both bipolar depression and MDD who take a serotonergic medication or another medication that helps them for depression always have a question. I'm feeling better, doctor. Can I stop my medication? Because of long-term side effects. You're suggesting the most dangerous thing long-term is inadequate treatment of mental health disorders like depression, because it causes the brain to shrink more quickly. And that we should really think carefully when there's a concern. There was some idea there's a compensatory change happening when patients are on long-term SSRIs. Could you help us understand a little bit about long-term safety of SSRIs? And it sounds like one way we should think about explaining them to patients is around the neurogenesis effect and the anti-inflammatory effect, that these aren't serotonin medicines making serotonin go up, and that you haven't thought about them that way for a long time.
So SSRIs have been prescribed to huge numbers of people for a very long time. They don't have a long-term cumulative toxic or bad effect. It just doesn't happen. We want people to take SSRIs to treat their episode of depression, which is usually a 6 months, roughly, course of treatment. And then we often will try, usually taper them off. But if the person has severe depressions that occur with a certain frequency, or their depressions are dangerous, meaning that they've made a suicide attempt, that they've been lucky enough to survive during a depression, we don't want them to have another episode. We want to prevent the next episode. So when they feel cheerful, yes, we do want to finish the 6-month course to make sure that they're not going to have a return of that episode of depression. But we're also then looking to the future and making a judgment for each patient. Is it better to just, go off the meds, and then when you get depressed next time, just come and see me? Or do we think, maybe it's too much of a risk? And this is a good conversation. Certainly, the patient has to participate and buy into this decision-making process. The family, significant other should be often part of this conversation, because they are the ones that often see the depression coming back before the patient does. This needs to be a team decision where all the parties feel, stakeholder, patient, doctor, all feel that they can that they've been part of this decision process. And then you decide, are you going to continue it long term or not? What's the downside of long term? Okay, some people don't like the side effects. Maybe most people don't like side effects. Of course, that's completely understandable. You're trading off side effects versus benefit. That's true of any medication. But the main thing with SSRIs is, if you've been taking them for a long time, you can't just stop it abruptly, because you'll get what's called discontinuation syndrome, which is very unpleasant. It's kind of like getting the flu, and you have these electric feelings in the head.
And a little visual disturbance. My patients complain, something goes by and I track it and I get a vertigo.
Yeah, people feel pretty horrible. But it usually only lasts a few days or a week or two, and then it just can progressively fades away. But you can attenuate it or avoid it by very gradually tapering the SSRI over a few weeks, and then the person doesn't get those symptoms, and then they're off it. This isn't a sign that the person is now addicted to SSRIs. There is no such thing as addiction to SSRIs. They have no addictive problem. They do not have the risk of, say, tardive dyskinesia that you see with antipsychotics. Their main problem is that they have some side effects, of which the most notable, really, I think, I mean, people are honest, are the sexual side effects. And then there are more minor side effects, like some people getting a tremor, there may be some GI effects, and so on and so forth. But that's weighed against the other factors, and that's part of the conversation.
It's such a hard thing, I find, for many patients who benefit from SSRIs because there's such a bias against them. And I hope sometime we could hear more of your thoughts on where that comes from. It's interesting to me that, you know, as you speak about antidepressants, it gives a reassurance of really helping on a biological level, and there being real clarity in the research of why that's happening, how patients are benefiting, and while there, you know, are some side effects, the real risks to patients of having untreated depression. And we know from the data that's quite true. We have the most disabling illness on the planet and in the United States, horribly undertreated. In men, I've seen statistics like 80% of men with depression don't seek any treatment at all. I think 50% of kids just with mental health disorders don't ever get treatment. So it's wonderful to hear some of the details of your research and also how you respond to this systematic analysis. It sounds, just to summarize, SSRIs continue to be helpful to patients. The data is fine and good long-term. You have no concerns about long-term, but also as you describe them, you think about them as neuroplastic agents.
Yes, that's correct. I see them as fundamentally changing the pathogenesis of the illness to help people get better. I think there's a huge stigma out there about SSRIs and all psychotropic medications. We have made significant progress in trying to reduce that stigma, but it is still enormous. I mean, you can see, you know, Black Lives Matter and all of this, you know, structural discrimination and racism and all of that sort of stuff. These beliefs have been hammered into people's minds for decades, and they don't go away rapidly. And they're still there. I still remember a reporter once said to me, you know, Dr. Mann, you know, there are, you know, millions and millions of prescriptions of SSRIs. Don't you think that's too many? I said to this reporter, you know, there are also millions of, unfortunately, prescriptions of drugs for cancer, for diabetes, for hyperlipidemia. Are you ever telling me that too many of these drugs are being prescribed? Or is it just a question of, are we adequately responding to a medical problem that's really out there that needs to be fixed?
Dr. Mann, thank you. I think also invoking that there is a structural discrimination against mental health patients, against mental health treatment. There is an incredible bias. Spending a lot of time in the integrative health world, it's surprising to me. I've become someone defending Zoloft often, of reminding people, hey, along with lifestyle, along with proper nutrition, many individuals need more help. They have a biological illness that needs treatment, and there's tremendous science behind that. I forgot one question, which is around the tryptophan depletion studies. And I just wanted to understand that. Is this because the brain is able to pull tryptophan from muscle, and that these studies are so short term that we don't actually need dietary tryptophan in acute sense to make serotonin?
The brain needs a steady supply of tryptophan. Even a short term, like, you know, an hour or two of cutting off the supply of tryptophan, and then the serotonin supply drops and the amount of serotonin release drops. It's very quick. You need to. The reason you don't see it, just by eating a normal diet, you have plenty of tryptophan. The only way we can produce this diminution in tryptophan in the brain is by flooding the person with this horrible drink of large neutral amino acids that compete for the transport side across the blood-brain barrier and cut off the supply of tryptophan. we are not depleting tryptophan in their bodies. We're only interfering with its transport from the blood into the brain for a short time. So a normal person doesn't get any benefit from having tryptophan supplements. Actually, our work shows that there's an excess of serotonin and an overabundance of serotonin neurons in the brains of depressed people. Their problem is not having enough serotonin. Their problem is related to the autoreceptor, which regulates the firing of serotonin neurons. That autoreceptor, for either epigenetic or genetic reasons, in depressed people and in transmitted familial, is excessively expressed, so that they shut off the firing too quickly, and they can't release the serotonin that they have. People are not suffering from a deficiency of serotonin; they're suffering from a deficiency of serotonin firing and release.
Thank you, everyone. I'm here with J. John Mann. Dr. Mann is a professor of translational neuroscience and radiology at Columbia University, and he directs the Depression Center at Columbia Psychiatry. What a masterclass on understanding the cutting edge research and all of the exciting brain research going on, that we're really beginning to understand these illnesses. I always feel an incredible sense of optimism speaking with you, because there is so much stigma and so much bias. And I think people have a hard time sorting through an article like this, as you say, a mediocre quality paper, in your opinion, and not really seeing the true science of all of the multiple systems that are working together to create our mood and create consciousness, and how disruptions in these are very clearly at the foundation and pathogenesis of illnesses and mood disorders like depression and bipolar disorder. Everyone, thank you so much for joining us. I'm Dr. Drew Ramsey, and we'll be back again soon.